So in the next room we have a 84-year-old female patient. She was seen in an outpatient clinic due to painless jaundice and weight loss, a high bilirubin on 301. The following CT scan revealed a double duct sign with a 3 centimeter large process in the head of the pancreas. She has a dilated CBD and intrahepatic bile ducts, as well as a multiple lung metastasis. She is now referred for EUS for histological confirmation and before the oncological treatment and stent placement at the same time.
Okay, so welcome. It's a pleasure to be here. Thank you for the invitation again with Dr. Pham. And we have this case that you just that was just described to you. We are in the cardia now with an Olympus 180 endoscope, and we are using a Hitachi Aloka Arietta 850 machine. So I'll briefly show you some anatomy and abnormal findings. So you see the ascites here around the liver. We're looking at the liver where we can appreciate intrahepatic bile duct dilation. We continue to the portal vein, which is in the middle. Maybe I will ask Khan, maybe he can, point with the pointer. And now you can see below or to the left from this is the bile duct dilated up to the hilum, and above it we see the portal vein. If we follow the portal vein, that should bring us to the body of the pancreas, which I'm doing, and you will see here, appreciate that there is not really much left from the we already see the cancer here. But we see behind the cancer this huge pancreatic duct dilation, can you please, and not really any much parenchyma around it, okay? And if I move towards the head of the pancreas, we can see this hypoechoic large lesion in the head of the pancreas. So I think this is enough for the stomach position. We'll advance the endoscope because the aim of the procedure is to do a biopsy. So I'm using an endoscopic view to get to the antrum and pylorus, and we'll try to enter the pylorus now. So I'm in the bulb, and you can now appreciate already, Khan will show you this hypoechoic, non-homogeneous, not regularly delineated lesion in the head of the pancreas. I think this is the pancreatic duct dilated. The dilation will start from here, and we can maybe also appreciate it's dilated, and if we enter the descending duodenum to finish the demonstration, then you will be able to see the dilation of the duct. You will see the tumor again, and we see plenty of ascites here. Now, when withdrawing slowly the endoscope, the tumor will come here on the right hand side. It's coming, and you see the So right above the tumor, there we have this dilatation of the PD, which is an indirect sign of obstruction and cancer being present there. So we'll now, because we would like to demonstrate to you 2 needles. Actually, they are both biopsy needles, so you can appreciate the cancer, the tumor now between the transducer and the dilated pancreatic duct. So I'll start with we would like to show you two needles. The first one will be again here now you see the cancer and the pancreatic duct dilated above it. So the first needle, maybe Khan can show you what I have here is
the new Cook Procore 20 gauge. And it is a little bit thicker than the previous ones, and it's a forward cutting compared to the previous models. So I give the needle to
So we take this off,
Thomas,
and we will put the needle down. Hopefully the scope is not angulated too much, so we will be able to go all the way down. We screw the needle. We may have to now move the sheath a little bit so that it comes in.
See that she's coming there, yeah.
So it's coming now here. So I think this will be a good position. Now we'll aim for the cancer, which is right in front of us.
You want to check with Doppler?
Yes, please do.
So I check here. This some kind of Is there a little bit air inside, I guess, but it doesn't matter. Just go for it.
So we'll try to position the needle here now. Take the stylet out a little bit.
Oh, that's a good position.
This is a little better position.
Okay.
So what I do, I try to put the stylet in a little bit to get rid of any possible contamination.
Yeah.
Now we take it out.
Do you want suction or not?
Yes.
Okay, then I remove. So what's special with this needle is that you see the stylet is curling by itself. So it goes in a round, so it's easy to put away. I make 10 milliliter of vacuum.
So I'm trying to hold the needle in a stable position.
I will open the vacuum.
Yes. So it's ready now. I'll try to move within the tumor and try to show you the fanning technique if possible. So going from one side to the other side of the lesion. Not sure.
So does it feel hard, Thomas?
Yes.
You want me to hold the scope?
By changing the wheel, I can the big wheel change the direction of the scope of the needle going in, going from one side to the other. So I think we are fine now. We've covered most of the lesion, so we turn this off, disconnect, take the needle out, lock, unscrew, and we are finished.
Okay.
And we will continue, and the second biopsy will be done with a
Any questions for Thomas or comments?
It actually may be better to approach the lesion from the distal duodenum. So we'll now get the so I move the scope towards the distal duodenum, and now the other needle will be a more flexible one. Are you ready? So the other needle that we want to show you is an Olympus.
Easy shot 3. No, they're without the side holes. So
this one will not have a side hole, and it is it has a metal sheath, and has this manganese type tip, which is very, very sharp. I don't know if you can appreciate it here. I think we did show you a picture earlier in one of the lectures, and it is made out of nitinol, if I'm not mistaken. So it's supposed to be very flexible, and it's supposed to keep its shape. So I'm locking everything now, putting it into the original position now.
What orientation are you using? Thumb, Can you tell us a bit about the orientation? What's your orientation in Bergen? Are you using the cranial, caudal, or left, right?
I use also, I don't know how. In fact, the same position which orientation as which I have now.
Okay.
So the instrumentation comes from the right side of the screen. So here, since the lesion is in the head of the pancreas, the scope position is rather extreme. I have the big wheel pretty much down, and so with this new needle from Olympus, it's very flexible at the tip, so I seems not to have a problem to take it out even with a very angulated scope. And so now I have already this needle a little bit, I have it ready, so that I'm just now try to find a good position. Okay, perhaps I have to go, back in the stomach. So that was your the spot you took biopsy from, but I wonder if I should go, because I think it is coming on the right side now. I try to. Wow, shit.
So this is what often happens, that once you're in the distal duodenal position and you slowly withdraw your endoscope, and eventually now the tumor is coming on the left, you lose the position.
It's could be. It looks like it is a tumor, but I think it could be also a very thickener duodenal wall. Because yes. So perhaps there,
this is the tumor,
that is the more. I think this probably this area here. Because if you look this area,
I think maybe we did the first biopsy.
Yeah, I think it's from here. Yes, because it looks like air in this area. So this is like the lumen of the duodenum. While if I turn a bit, yes, then you see this lesion here. Okay, then is the scope position is not that bad. So I take out the sheath, and already here you can see that's the opening is here of the sheath and the layers. So I usually take out the needle so that I have it right at the tip, and then I pull back the style a little bit, and then I aim, and then I try to measure. It's around perhaps 2-3 centimeters, so I lock around that area, and then it's hard. Okay, so then we have to use force. Okay, so I'm in, I push out the stylet, and then I try to move the needle back and forth a few times, make a slow suction here. Slow. And try to fan it a bit. Perhaps could you help me to this?
Yes, sure. You want to slowly
you can just pull. Yes, this is a 19-0 needle, and it's very flexible.
He doesn't want to have suction.
I think I take some suction, so this is rather hard. It's already made there, I think. It's on.
I'll do it.
I try to keep an eye on the tip of the needle. There's like a dot. If you see here, this is I call it guiding star. So as long as I have an eye on that, I know more or less where I am. Okay, so now we close, disconnect, and then we remove everything. So, I
guess we should do then.
So we have been discussing what to do next with the patient, and we plan now to do an Ercp to drain the common bile duct, because it's she will need that sooner or later, and I think we will prepare the room.
Yeah, maybe we do another pass, because I think I did not do a biopsy from the...
Do you still have the cook needle? Then I tried another pass. Perhaps you would.
We have a question for you, Thomas.
It's very likely that I was not in the tumor, I think, actually. So this is a better situation.
Yeah, hello?
Thomas.
Yes.
I'm just giving a question, because now we've done the biopsy. It seems that there is a mass, at least in the pancreatic biliary area. So what is this, in the big discussion today is, should we in this case go for an Ercp, or can we plan go for a choledochodonostomy?
Okay. I personally think we should attempt...
I have to try another one.
Okay. I think we should attempt an Ercp first. I mean, we know now that the endoscope can be passed down all the way to the papilla, at least this scope. So I think... is this the Olympus?
Yes, because turns out that I didn't get any materials with the Olympus, so we try with another pass.
We need to make sure that we are puncturing the tumor, which this probably is the tumor. I think in the first pass I probably was not in the tumor, rather in the thickened duodenal wall. I guess this is the tumor.
Yes, that looks like, yeah. Okay.
So the suction, you can appreciate the visibility. So there is some there are some first reports now of people doing primary EUS guided drainage, not attempting Ercp. I guess this is what your question was aiming to.
Yes.
So I still think that Ercp should be, So I hope this time we are in the cancer. I think the first time I'm not sure, so I'm trying to cover the lesion. I'm not really used to working with this Histology system, so therefore having little difficulties, really distinguishing different. So hopefully this is the cancer. And so I would go for your CP first. Any disagreement or?
Yeah, the patient also has ascites, so I think that's one of the problems with the EUS bile duct drainage as well. But we have one more question from Paolo.
Looks like this tumor is a duodenal tumor invading the pancreatic region. So I think that I would agree with Julio that probably there are data nowadays from 2 randomized controlled trials that suggest that choledochoduodenal has the same result as compared to Ercp, but is quicker. So probably in this case we are dealing with a 84 years old patient with also metastatic disease. Probably it would take shorter time to perform the EUS guided drainage with the same instrument that go for the Ercp procedure.
Okay, just to make the fight fair, I am back with the Cook Procore 20.
I'm not sure if this is. I'm not sure if I heard you well. Were you saying that this was a duodenal tumor, and
Tom, can we see the specimen, or Thomas, because we
Yes,
have
I'll try to look.
We have
Do we
to
have
move
anything?
on for the lecture. So if you could show us the specimen, that would be great.
Okay.
Oh, it's a very different consistency. It's really hard. Could you pull it out for me, please? Yeah. Yeah, hold it again. Ja, jag tar sug på.
Well, we did not see any obvious, I think, cancer on the endoscopy view. Like that there would be a cancer of the duodenal mucosa infiltrating the pancreas. I'm not saying that it's not possible. Definitely there is a very, tied in close relationship of the two. Sorry.
And so we remove everything. So we are probably while they're going over a lecture, we can do the Ercp.
Can we see the specimen just before going away? Or
Yeah, if you can show the specimen, I don't know if you can move the camera towards the specimen. So we are putting the specimen here in liquid. So this is the Cook site hole needle. So we are introducing the stylet back into the needle. Finished? No. So, okay, so it doesn't want to go now all the way. Now something is starting to come. I don't know if you can appreciate what's coming.
now we can see it.
So we are getting mainly... So far it looks like we are getting blood.
That's all.
So this was the last cook. From some of the previous ones, we did see some more biopsy. Yep.
We do have two cook as well now.
Okay.
Okay, so if there are no more questions, I think we will move towards the lecture. Thank you very much, Thomas and
Thank
Fam.
you.
Thank you. Thank you.
Okay, and we received some macroscopically what looked like fine needle biopsies, thread-like tissue elements suspended in cytolite, and we made cell block histology specimens from those materials, and they have proven to be of a high quality and very rich in cells. Let me just focus this for you. Just scanning through one of the specimens. Actually, we had two. You made aspirates with two different needle types, I believe, right? One was 20 gauge from one company, and the other was 22 gauge, I think, from another company. Yeah, and this one was I think this was the 20 gauge. And the most, the first, this was the first one taken at it, and it was the one having the most material And the second needle biopsy, the second aspirate contained less material, but both were diagnostic and they were similar in content of cells. Oh, wrong way. And I don't know if you can appreciate that we have a lot of loose fragments and the flakes of columnar epithelium with varying degrees of atypia, varying degrees of dysplasia. If you look at some of the cells in this image, we can surely agree that they are abnormal, they are neoplastic, and they are malignant. The beauty of the cell block histology is that sometimes, besides the epithelium itself, we have cores of stroma, and actually the diagnostic feature, the diagnostic criterion for malignancy is stromal invasion, and stromal invasion is what we have in a tissue fragment like this. It's a stromal fragment with invasive growth of neoplastic malignant tumor cells. So from a histological point of view, this is PDAC. This is pancreatic ductal adenocarcinoma. We received 6, 7, 8 biopsies. 4 of them were quite large, like these that I'm going to show you, and some of them were smaller. Okay, I don't know. Here you can see 4 quite large biopsies from the duodenum, and in one of them, in one of them, one can appreciate an area of ulceration here, and in the bottom of the ulcer, you have some suspicious-looking cells. You have reactive-looking glands as well, and maybe reactive-looking Brunner glands, but also loosely arranged abnormal cells, and we find those also in one of the other biopsies. In this biopsy, we have, I think, some loosely arranged abnormal cells in the lamina propria, and I don't know. I can't even. Yeah, well, they're here and there admixed with inflammatory cells and reactive stromal cells, but we feel quite certain that cells like these represent the adenocarcinoma from pancreas, and that they actually have invaded the duodenal wall. Yeah.